section, we will learn about the challenges that we can face when we image pediatric patients. We will focus on pediatric protocol development and the requirements for pediatric CT, followed by a conclusion. When we talk about the challenges of pediatric CT and what we can face when imaging pediatric patients, we are going to look at parent communication and the variations in clinical practice, which are all considered challenges of imaging pediatric patients. Parents just want to protect their children, and in the age of the internet, a lot of information is readily available about the risks of imaging exams that use ionizing radiation. Some of it accurate, some of it wildly inaccurate, or very misrepresented. And parents, largely, do not have the background to be able to distinguish the fact from fiction in this area. In fact, the general public perceives, understands, and estimates risks quite differently from trained professionals. And so, many parents are quite understandably afraid of subjecting their children to radiation. Here, you, the technologist, plays a critical role in communicating information to the parents. It is important to remember that simply providing information to parents is not the same thing as communicating. The information needs to be provided in such a way that parents or caregivers truly comprehend its meaning. These risk communication conversations can be challenging, especially in pediatric imaging. You need to be empathetic and understand how parents are feeling in order to address their concerns, and you need to be knowledgeable and up to date in order to answer the questions parents will ask. Risk communication strategies should take into account that each individual parent and family unit are different. They come from different cultural backgrounds, they have different experiences, and their perceptions of the healthcare institutions are very different. Here we'll look at the broad strokes of what information you should include when talking to parents in terms of the challenges of pediatric CT. In order to make an informed decisions, parents need to know the real risks and benefits of performing or not performing a given CT exam on their child. You should be able to explain to parents or caregivers what information the exam will provide the healthcare team, how that it will be used to help their child, and that these benefits outweigh the risks of the exam. You'll need to explain in clear language, not medical speak, that their child will receive only the minimum radiation dose that is necessary for the exam, and that the risk of cancer as a result of the exam are low. Here, it is important to explain that there are specific methods and procedures that are used to control risk and to reduce the amount of exposure their child will receive, while still giving physicians the information they need in order to treat their child. You should also clearly explain the consequences of not conducting the exam and what, if any, alternative procedures can be done to gather the information that is needed to diagnose and or treat their child. In Image Wisely's How to Understand and Communicate Radiation Risks, Drs. Peck and Sami provided a useful table of do's and don'ts for communicating CT risks, which are shown here on this slide. Further elaboration for understanding and communicating risks in pediatric imaging can be found in Dr. Fresh's webinar, Strategies for Communicating Radiation Risk for Medical Imaging in Children, which was organized by the International Atomic Energy Agency, or IAEA, and the Alliance for Radiation Safety in Pediatric Imaging, the Image Gently Alliance, and is available at www.iaea.org, searching for Communicating Radiation Risk for Medical Imaging in Children. The World Health Organization, or WHO, also offers a robust guide to communicating the risks which are associated with pediatric imaging. Here are some of the do's and don'ts when communicating risks. In the category of truthfulness, tell the truth, do not lie or avoid the truth. In clarity, ask whether you are understood, and do not assume understanding. This chart is pretty comprehensive. Additional challenges of pediatric CT are the variations in clinical practice. Another challenge in optimizing pediatric radiation doses are variations in clinical practice. This occurs among several facilities and even with a single department in the same facility. In a study of pediatric head CT protocols used at different level trauma centers in Washington State, Connell and colleagues in 2011 found that while most of the trauma centers reported having established a specific protocol for pediatric head CT, many facilities reported lacking dose reduction strategies entirely, with level 3, 4, and 5 trauma centers tending to have higher MAS. In a study spanning the healthcare facilities in the U.S., Europe, and Japan, Robin and al. In 2020 asked institutional leaders what they thought the barriers were to consistently optimize CT dose, or in other words, what leads to variations in practice and inconsistency in CT dose optimization. The 6 issues leaders consistently mentioned were: number 1, resistance to change; number 2, limited time and resources; number 3, complex organizational structure; number 4, lack of leadership support; number 5, variations in CT equipment; and number 6, variability in CT protocols. Smith, Bindman, and colleagues in 2019, while studying adult CT radiation dose variation, found the dose differences among countries could not be attributed to differences in patient characteristics or characteristics of the institution examined, or even the manufacturer, machines, or models. Variations in dose were, quote, almost entirely associated with how institutions use the machines, presumably reflecting different decisions about technical parameters to yield optimum CT images. In other words, decisions made by staff about technical parameters had the single greatest impact on variation in CT dose optimization. This emphasizes the need for technologists and other members of the healthcare team and leadership to determine a fixed set of acquisition parameters and protocols for children that are applicable to the variety of scanner models in the department that will maintain the image quality necessary to answer clinical questions. Technologists must then adhere to them as well as to ALARA principles. Greenwood and colleagues evaluated variations in CT scans of the head. Comparison of CT dose measurements showed substantial variation even when repeated studies were performed in the same patient. Several age and condition-specific head CT protocols were available on 2 scanners, and greater variability was observed on weekends and on evenings. We will now focus on pediatric protocol development. The number of resources for pediatric CT dose reduction strategies and pediatric size-specific protocols are growing. We must still contend with the issue that many protocols are only applicable to specific makes and models of scanners and cannot be implemented on other scanners. This makes knowledge management and technology experience even more important. As part of their effort to change clinical practice to reduce radiation exposure in children, the Image Gently campaign has published general considerations for dose reduction. They include: limit the range to the region of interest. Use low-dose SCOUT scan to determine the minimum scan range and the position. Limit the number of contrast phases. Using unnecessary multi-phase exams can add substantial excess radiation to the child. Be sure and center the patient. Adjust the exposure parameters for pediatric CT examinations. Tailor the CT parameters to the size and weight of the child. This means increasing the collimation, lowering the KVP, and lowering the mass. And finally, using iterative construction. Image Gently goes beyond general recommendations, though, providing the basic objectives for that are required to establish pediatric size-specific protocols and detailed procedures for accomplishing each of those. Image Gently also directs readers' attention to the works of Strauss in 2014 for a more thorough and in-depth step-by-step explanation of the process for departments to develop appropriate diagnostic reference levels, or DRLs, and thereby pediatric protocols. Strauss's method addresses every CT scanner, as he puts it, regardless of vendor, model, or vintage. His work specifically addresses head, thorax, and abdominal and pelvic CTs. Further, the AAPM has published routine pediatric size protocols for chest CT, abdomen and pelvic CT, and head CT. These are open for feedback and available at www.aapm.org/pubs/CT/protocols. So what are the requirements for pediatric CT? As our understanding of the dangers of increased use of CT scans in the pediatric population has improved over time, regulations and requirements have been put into place by manufacturers and other organizations that help to reduce the dose levels that are delivered to our patients. The National Electrical Manufacturers Association, or NEMA, requires that all new CT scanners include 4 standard attributes that, quote, contribute to or help perform optimization and or management of doses of ionizing radiation while still enabling the system to deliver the diagnostic image quality needed by the physician. These 4 attributes are DICOM dose structured reporting, features and functionality that conform to NEMA XR-25 computed tomography dose check, automatic exposure control, and finally, reference pediatric and adult protocols. As facilities replace older CT scanners with newer models that are manufactured with these dose reduction features, and as image processing technologies improve, facilities are reporting sharp and substantial increase in dose reductions. Radiology departments are required to track dose levels of their scanners and to compare them with those of other facilities, either by participating in the ACR Dose Index Registry or by using a commercial software which is designed to track radiation doses. So, in conclusion, though its convenience may have led to a surge in its use in the not-so-distant past, recent research shows that the use of pediatric CT is declining, though some estimates suggest as many as 1/3 of all CT scans still may be unnecessary. But even with higher radiation doses associated with it, CT remains an invaluable diagnostic tool, the benefits of which most often outweigh the risks. It is crucial for technologists to remember that a large part of dose optimization rests in your hands, as changes in technical parameters have been shown to have the greatest impact on dose variation. It is you all who ensure that protocols are adjusted to child size and that all opportunities for dose reduction are identified and taken while image quality is maintained. It is you all who ensure that your facility's radiation dose reduction strategies and pediatric protocols are adhered to with consistency in practice, including CTs performed only when necessary, limiting to the size of the area of the body being analyzed, adjusted protocols being used, and a quality assurance program. Thank you for choosing medical professionals as your continuing education provider. We hope you found this course interesting and valuable. Before you take the post-test, please be sure to look over the module objectives to see if you need to review any of the information that was presented in this module.